I call this hearing to order on Medicare physician fee cuts. Can small practices survive? Our healthcare system is facing many challenges today that are not only affecting patients but also medical providers. One of the greatest obstacles confronting small healthcare practices is the fiscal problem in the Medicare program. With the baby boomer generation entering retirement, Medicare spending will increase exponentially over the next 10 years. Efforts are underway to ensure access to health care remains, while also meeting the long-term financial issues facing the program. One of the top priorities in the upcoming months is addressing the scheduled cuts in physician fee payments. On July 1st, physician payments for Medicare services are scheduled to be reduced by 10.6%. Without action, these cuts will continue annually, and it is predicted that the total reduction will be about 41% by 2016. Practitioners have warned that cutting doctor payments will undermine the physician foundation of Medicare for current and future generations of seniors, creating unnecessary barriers to care for older Americans. An AMA survey found that 60% of doctors believe this year's cut alone will force them to limit the number of new Medicare patients they can treat. This hearing today will examine how any solution must account for small healthcare practices. In crafting a fix, the unique circumstances of small healthcare providers must not be ignored. It is clear that they could be the most severely affected. Doctors' survey by the American College of Physicians said cuts will force them to postpone purchases for their practice and to reconsider plans to upgrade health information technology. Other providers went further, saying they will reduce their staff or get out of patient care altogether. Unfortunately, the administration has taken the position that the cuts are necessary even if it could mean loss of access for our seniors. In finding a solution to this problem, CMS must be an active participant, which is why the committee has invited CMS here today. The committee looks forward to CMS testimony on what they are doing to work with the physician community. It is critically they hear the concerns of medical professionals here today and across the country on the potential implementation of these cuts, as well as ways to mitigate their impact. This includes reducing the paperwork burden and providing regulatory relief to help physicians reduce costs associated with operating a practice. With the cuts little more than a month away, there are steps being taken to avoid this problem. The question simply becomes, how should it be done and what does it mean for physicians? The Senate has outlined a plan that will delay the Medicare physician payment cuts for 18 months. I support their effort to address this problem in the near term, but I also believe we should be working to finding a more permanent fix to Medicare's physician fee cuts, one that reflects the cost increases inherent in practicing medicine and preserves access to coverage for seniors. Any fix needs to address the needs of small physician practices. A solution that doesn't meet this goal could mean that patients could face problems in accessing health care in the future. I hope that during today's hearing, our witnesses will shed light on the steps they believe should be taken. It is also my hope that the panelists will provide insight on the short, long-term impact the cuts could have on the provider community. In many ways, the physicians' community interests are aligned with those of the seniors that receive care. The committee wishes to hear these concerns and how we can work together for a proper remedy. I look forward to today's testimony, and I thank all the witnesses for their participation. I now yield to Mr. Chabot for his opening statement.
Thank you, Madam Chair, and good morning to everyone, and thank you for holding this hearing on Medicare physician fee rates and cuts, et cetera. This committee and our nation recognize that small medical practices are critical to the country's overall physical and mental health, and like all other small businesses, essential to our economic well-being. I'd like to extend a special thanks to each of our witnesses who have taken the time to come here and who will be providing testimony here this morning. I especially want to welcome Dr. Charles Mabry, who is testifying on behalf of the American College of Surgeons. I'm sure that we will find his testimony and all the witnesses especially helpful. And I also want to especially thank Tom DeAngelis, who's from the greater Cincinnati area, who will also be testifying this morning. Data on medical practice size show that physicians and patients continue to prefer small practice settings. The small setting allows the physician to have control of medical decision making and is most conducive to the relationship of trust and confidence between physician and patient. The practical preference of the small practice setting suggests that any Medicare physician fee system must be feasible and easily operable in a small practice setting. The managed care backlash is also driving the insurance industry toward traditional insurance principles that instruct insurers like Medicare to manage financial risk and allow providers to manage care. The insurers' forays into disease management emphasize this change in behavior with only cautious and limited outreach to physicians. The current Medicare physician fee schedule is clearly flawed. Since its inception in 2002, the sustainable growth rate formula has required the government to reduce physician fees. Since 2003, Congress has passed and the President has signed laws that have prevented the reductions from actually taking place. The current system rewards the physician for seeing as many patients as possible and sometimes performing excessive services. An example of this practice is the use of a CAT scan sometimes rather than an X-ray, for example. Several studies have confirmed that expensive or excessive services do not necessarily lead to better quality outcomes. As physicians' costs go up and their Medicare reimbursements drop or are unrealistically low, they're engaged in a vicious cycle that forces them to see more and more patients to take in the same amount of money. Medicare pays its providers based on quantity without rewarding those providers who improve quality. In fact, Medicare pays more when poor care results sometimes in preventable services. This needs to be changed. Today, access remains good for beneficiaries accessing current physicians and for those seeking new physicians. Continued efforts to monitor and protect Medicare beneficiary access are warranted. The Medicare physician fee schedule should be restructured to place a greater value on the quality of care and the efficient use of resources. Attention should also be given to improve health IT efforts. Making electronic Medicare records available to patients' physicians will cut down on unnecessary tests, help doctors provide better care, and offer economic benefits to taxpayers and the federal budget. We have an excellent panel of witnesses, as I mentioned before, here today, and I look forward to hearing their thoughts. I want to thank the chair again for holding this important hearing, and I yield back the balance of my time.